Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Brad. How are you doing today?
How you been, man?
I'm doing well. So the reason why I asked you to come on is you know drugs really well. So if you wouldn't mind just doing a real quick introduction of yourself.
Well, to keep it kind of short, I'm retired now. I'm a retired CRNA anesthetist. I was in the Army for about 22 years, both enlisted as a medic and then later crossed over to the dark side and went into the anesthesia world. Was just finishing school when 9/11 happened. And then after that, got over into the JMAL unit and did a lot of time over there. Most of my time, about 13 years over there. Spent a lot of time with a lot of the medication protocols for the schoolhouse, for the soft handbook, ketamine protocols, all that kind of stuff. Did a lot of things with research and development as well. And had a hand in training quite a few people in sedation protocols and that type of the world. So in a nutshell, that's kind of it. And I love jumping out of airplanes too. So
Nice.
Yeah. So
well, you're the perfect guy for this. So
okay, I'm a guy.
You're the only one that answered the email. So
Okay, well, there you go, man. All right, I'm in. All right.
So today I'd like to talk about Nubain.
Yeah.
Okay. And
absolutely.
so when I first heard about Nubain, it sounded like the perfect opioid. It gave you all the pain control with none of the negative side effects. When I finally got to my unit, there was no Nubain to be found because it was evil and it killed everybody. So hearing that it's used actually in other places in the world, it's still a thing that's made every day. I think it'd be smart to learn how to use it just in case you happen to run across it. So if you could, please give me some kind of background information on it. Like, how does this work?
Yeah, so interesting enough, it's a little bit of history. I'll help explain it. Ever since morphine came into the world, which was back during our Civil War, all the way back in the 1860s, it was the drug that we have compared everything to as far as narcotics go. It's the benchmark. However, as we look into older medications that are still around to this day, I always talk about them being the older the drug, typically the more dirty the drug is, meaning it has a lot of untoward side effects that we just don't like. And so we hope that as we develop newer type drugs, we clean those drugs up and hopefully we can remove the side effects that we don't like and we can just get drugs that work on things that we want them to work on, I guess is the best way to explain it. During the 1960s, a lot of effort was done at that time. You know, ketamine came around in the 1960s. Another group of drugs that was being worked on then were called the agonist-antagonist. And that is a category that the two drugs that are kind of still around today, one is Nubain, and the other name for that is now Bufene. And the other drug that we hear about still is called Stadol or butorphanol. Now, we're going to stay away from that drug today, and we're going to focus on Nubain, but they're in the same drug category, the antagonist and agonist side of the house. So what does that mean exactly? Well, it got FDA approval in 1979. And it started being used in hospitals in the 1980s and 1990s. And back then, as any kind of new drug is, it's kind of the new hotness, so to speak. Throw your morphine away and here comes Nubain and it's going to solve all your problems. All right. An agonist antagonist, one of the best ways to kind of think about it is if I had a syringe and in that syringe, I drew up, and let's just say it's a 10 cc syringe, and I was to draw up like 8 cc's of morphine. And then the other 2 cc's of the syringe, I actually put Narcan in the same syringe. Okay. Now, if someone's going to have a nosebleed right now about JCO, you can't mix drugs, whatever. Okay. I'm giving you a visual here. Okay. So I'm actually putting in the agonist morphine, the painkiller, but then I'm sprinkling in the antagonist, Narcan, that is actually reversing the effects of the morphine. That's basically what they did in a nutshell. Okay. Now, did it work? Partially. I mean, it is a good, relatively good painkiller for pain. The interesting thing is it's exactly the same strength, or exactly very close to the same strength as morphine as a painkiller, which is a good thing as far as like when we start to talk about dosing it, because it's very easy to relate. If I was to give morphine, then I would give the same Nubain dose type of a deal. And then they sprinkle in the Narcan type of the drug to reverse what we're hoping is the side effects that we don't want. Well, what are some of the bigger ones that we really, dislike about morphine? Well, number one, respiratory depression. Okay. We don't like the histamine release out of it. The euphoria that people get from morphine or Dilaudid or those types of drugs, and also that ties kind of into the abusive effect of those drugs. Maybe we could strip that side of the drug away. Other things like urinary retention or the itching, the pruritus that the drugs can cause as well. So that was kind of the idea behind it. The other interesting thing about Nubain is when it first came out, it was a Schedule II narcotic, meaning it was a controlled substance, just like morphine, just like Dilaudid, yada, yada, yada. However, one of the things they seemed to mostly have solved was it didn't seem to have the abusive effect that the other drugs had. They went back to the FDA and they actually got it taken off the controlled substance list. That's pretty good. Right. That's a pretty big thing. Right. Now, other countries, I think Canada, it might still be considered a controlled substance, but other countries, have their own rules with things. But as far as the United States, it's not a controlled substance. And it's the only narcotic out there, unless something weird has come out since then, that's not controlled. So that's that's another Benny. Right. Yeah. I can put it in my bag and it's not a controlled substance and I don't have to worry about the headaches that go along with that as well. So that's kind of the history of it. Now, like any drug, whenever it comes out, people, immediately were kind of start to jump on, well, I'm just going to use this instead of morphine. I'm going to use it instead of my fentanyl, yada, yada, yada. But typically it works okay on pain. But it's also, again, remember, it's kind of reversing some of the effects that it's having on pain. So you don't see the same effect as far as pain control like you see with morphine. Okay. That side of the house. So still today, though, it's a drug that's being used in like emergency rooms. Back when I was working in emergency rooms, back in the 90s, it was a drug that was used quite a bit on what you might consider a lesser pain syndrome. Maybe it sits kind of in between Toradol and actual morphine. If something sat in the middle of that, then I could try and give them Nubain. The really cool thing is most of the respiratory depression that we worry about with like morphine, Nubain's not as big of a deal as far as the respiratory depression. And we can talk about that a little bit more. It has this, what's called a ceiling effect, meaning that once you get to kind of a certain dose of Nubain, you're not going to get any more respiratory depression with it as well. So, so a lot of times people will look at it and be like, well, holy cow, this must be the most awesome thing in the world. It's just as strong as morphine and I don't get a lot of these other, bad effects from it. as far as side effects that are a little bit different with Nubain compared to morphine, you're dilaudid in morphine, you tend to see people get that euphoric effect. It's like, once it starts to hit.
I hate that.
Right, exactly.
You're in the Army. You will not be happy.
Suck it up, Buttercup. but the one movie that used to kill me was the movie Navy SEALs back in the day with Michael Biehn, when he gets shot and they're in the car and the one guy hits him with a morphine syringe in the leg. And he immediately is like, oh, this is you're like, wow, that's crap. But your Nubain, you don't see that effect. However, you see a different kind of effect at times of dysphoria, which that's a little not okay in the terms of meaning, like, I've seen people like get really agitated on it. I've seen people like describe like they feel like they're trying to crawl out of their skin. I mean, they get like even to the almost combative if you try and keep increasing the dose for that person, because the receptor that Nubain hits, the agonist side of it is working at that dysphoria receptor, but it doesn't have the antagonist side on the flip side. So they don't get the euphoria, but in certain people, when you start to see the dysphoria, I tend to switch drugs. I'm like, okay, you know what I mean? I don't want to keep going down this road, because the more I give, it's not really going to get better,
Okay.
The other thing that Nubain has been used for is if people get morphine and they start the really bad itching, you can actually reverse some of the itching effects if you switch them to Nubain.
Okay.
Or if they have like an exaggerated effect with respiratory depression on some of the other drugs, you can switch to Nubain and still maintain a certain level of pain control without all the respiratory depression that you see with the other drugs. So in a nutshell, that's kind of where it sits. So
now, I mean, does it do a good job at that reversal? Because I would think that it would be better to just use that versus Narcan.
Well, it depends on the situation. Sure. So basically, it's not as strong in the sense of Narcan as if you have somebody that is not breathing. I'm not reaching for Nubain to reverse, especially at the dosages that we're talking about. What we're really thinking more about is if I have given someone, let's say 10 milligrams of morphine, and they're only breathing, 4 times a minute, 6 times a minute, I'm not okay with that. I'm not going to I can switch to Nubain on my next dose, and some of that will start to reverse, or I don't even have to wait. I can start to switch over to the Nubain, and some of that reversal effect tends to kick in, and they start, picking up the respiratory rate. Yeah. Okay. So for sure. Rate. Yeah. The other interesting thing about Nubain compared to morphine, because it's so similar as far as the drug compound that's in it on the agonist side, its onset time is the same as morphine. Okay. So when you're giving it IV, it takes 3 to 5 minutes for it just to start. Yeah. And its peak effect is still like 15 minutes. And its duration, if it's IV, is typically 2 to 3 hours. If it's IM, it can be kind of more that 3 to 5 hours. So very, very similar to morphine, and very similar in the dosage range as far as morphine goes as well. So very, very similar as far as all those effects go. Yeah.
Using it in like a trauma scenario, hypotension, things like that. At least all of the drugs I'm used to, you need to cut the dose just because of the potential effects, at least on the hemodynamic side. Would that still kind of have that, or would you do that same type of thing with something like Nubain, if it has that agonist-antagonist effect? Or
you can. In fact, anytime I'm in one of those trauma scenarios, I tend to not tiptoe, but I'm always going to let make the patient prove to me they need more. You know what I mean? So I'm always going to start low and add to. If I'm looking at somebody and, you know, I say to myself, I'm going to give them 2 milligrams of IV morphine. Well, I would give them the same 2 milligrams of IV Nubain instead, you know, kind of a deal. So as far as that goes, I'm not really, you know, changing my dose that much. Nubain's interesting because it has that kind of Narcan effect. And you're not getting the histamine release that you see with your morphine. You may actually see increases in heart rate, and you may see increases in blood pressure. Not so much if someone is hypovolemic already, but you're not going to see the drop as much as if you were to give them morphine. So definitely, you know, in that side of the things, it's a little bit safer than it would be to consider. Morphine's really not a great trauma drug for anybody that's bleeding, you know. Trying to get that through to some people like is, you know, okay. Right. So, yeah.
Now, when you're talking about increases in blood pressure, heart rate, are you talking just a couple of points, or are you talking like a something to really watch out for?
Well, it's dose dependent. The more that you're giving of it, you might see it start to creep up. If you're giving somebody kind of that 5 milligrams IV dose of it, it's really not going to be a big deal unless they start to get that agitated side of the drug going. If they're one of those people that start to have anybody that's agitated, you know, their heart rate's going to go up, their blood pressure tends to go up. So it's kind of more of that side of the house type of a thing. So, yeah.
What kind of scenarios that you could see, what kind of patient models would you think Nubain is probably a really good drug to use on?
Well, I think you got to ask yourself a couple of questions. You know, Nubain is a tool in my toolbox. You know, I hate whenever people kind of go in and they say like, well, I'm going to remove this tool and just put this tool back in. You know, at times it's one of those things that if you've got it, it can be used in a lot of different scenarios on people that maybe I just don't want to use up my morphine or my fentanyl, you know, for something that doesn't appear to be as bad. Some of the orthopedic injuries, back injuries, you know, any of those kind of scenarios. Guys come in for, you know, things like migraine headaches or, you know, we're talking sick call stuff, you know, at times, you know, and I don't want to burn through all this other stuff. Or maybe, you know, in terms of, you know, I've got somebody. The other interesting thing about pain is sometimes it's a cultural thing. Meaning, you know, Americans expect to have no pain. You know what I mean? And you go to other countries and it's amazing what people don't even ask for, you know, in those deals. So sometimes it's like, hey man, it's not that bad. Let me give you some Nubain. And if you sell it the right way, it's almost like saying, hey, I got this cool new drug called placebo. And if you sell it right, you know, it tends to work a little bit, but it's
saline.
Yeah, exactly. But Nubain, it's a decent narcotic. It just doesn't, in my personal opinion, you know, giving it to a lot of different people in a lot of scenarios, isn't just quite as effective as it's the same dose of like morphine or Dilaudid. Now, some of that I do think goes back to when we were talking about expectations, because if somebody has had morphine in the past, they're expecting that kind of euphoric effect as part of their pain control. And it's like, no, that's not the same thing, you know. Or a good friend of mine had surgery a while back and he gave him Dilaudid, and he goes, I was like, well, so how was it? And he goes, I don't know if it did anything for the pain, but I was so jacked up in the head, I didn't care. You know, that kind of a thing. So Nubain is not going to give you that effect, you know. And again, back in kind of the 80s and 90s, if you had someone come to the hospital, especially the ER, you suspect it might be kind of a drug seeking type of a thing, well, they would give them Nubain. People get upset. You know, because they weren't getting the effect they wanted, you know, and that was kind of a key too, to be like, oh, okay, you know, so in that kind of a deal, maybe I want to save my other stuff for much more bigger scenario type events. Okay. It may be the only thing I've got.
Yeah.
It absolutely might be I'm in a scenario or I work in a country where this is all they're going to give me. And I need to know how to use this correctly and to the best effect. And that's why I said, like, the nice thing about it is it's nice to have under stress, kind of like a benchmark because your brain kind of under that kind of stress runs home to mama a little bit.
Yeah.
So I always try and relate things to, like, well, how does it compare to like 5 milligrams of morphine or 10 milligrams of morphine? And the good news is it's the same, So if I go into dose Nubain, then that's where I'm starting. 5 milligrams IV, I can go up to 10 milligrams. And the nice thing is you do see some respiratory depression, but you don't see it nearly as much typically as far as morphine or Dilaudid. Now, the other nice thing about that too is once you hit 30 milligrams, that's where we're at the ceiling effect.
Okay.
And so at that, if I have given 10 milligrams and I've given 10 milligrams for whatever reason and 10 milligrams and I'm at 30 and they're still breathing 8 to 10 times a minute. If I give them another 10, they're not going to drop anymore.
Okay.
Because you've got enough of the antagonist going at that point that's you've seen what you're going to see as far as respiratory depression. So
now that's obviously over a shorter period of time.
Correct. Right? That is correct. So, again, it's going to last 2 to 3 hours IV. So let's say now you want to let your drug work, right?
Yeah.
A lot of times we get into that scenario where people start giving a drug and they just don't let it work enough, which is kind of like a nice backstop with Nubain. If you accidentally gave 10, and then it all started to work, whatever respiratory depression I have, that's it. If you did the same thing with your morphine, well, they're not breathing once it all starts to metabolize and starts to hit. And now you're reaching for your Narcan or whatever, type of a deal. Which brings up another good scenario is that Narcan being the reversal, Narcan is actually the reversal for Nubain. It's just you really never need it. Type of a deal. And I get asked a lot, can I reverse respiratory depression of morphine or Dilaudid or fentanyl with Nubain? And the answer is yes. Caveat where if someone has stopped breathing, if they've gone to that part, no, I'm not reaching for Nubain. I'm reaching for Narcan. I need to reverse if I'm going to reverse the drug. However, if I have someone that has just kind of gone down into that, again, maybe they're only breathing 4 to 6 times a minute. I'm uncomfortable with that. I don't want them to keep going down further, but I don't want to use Narcan and reverse their pain control as well, because now I got a rodeo on my hands. Yeah. Nubain is nice because now I can go back in with Nubain. I can give 5 milligrams of IV Nubain, to start with. I'm not taking away all that pain control, but I'm starting to reverse the respiratory depression of the fentanyl, the morphine, or the Dilaudid, so to speak. And then I can continue with the Nubain and maintain a level of the pain control. And that can be a really, really great thing for you, especially if you're in kind of like a prolonged care environment, where, you're going to be sitting on this person for hours, and I need to use the morphine for somebody else anyway, or fentanyl or whatever it is. So that's another way to go.
Nice. So I'm right that there are some countries that's the narcotic you're going to get is Nubain, and there is no real patient selection. If they need some kind of opioid, like they're getting Nubain, right?
That's what you got. That's right.
That's the only thing I got. I've got that and a rock. Yeah. So
but
luckily, us in the Western countries generally have the fortune of carrying more than one type of narcotic. Usually we end up with a very fast acting drug, and hopefully we have some longer acting stuff. So let's say I've been using ketamine on somebody over and over. Usually what I'll end up doing, I'll do pushes of ketamine and go into like a drip for maybe an hour or two. And I figure within a couple hours, I'm going to have this thing settled one way or the other. But then I would like to try and save my ketamine for other patients that come in. How can I kind of transition from one narcotic into using Nubain in a safer way?
Well, we'll back up one little step.
Sure.
So that ketamine is not really a narcotic.
Okay.
Ketamine falls into an induction agent. It does have some effect at the mu receptor, which is where your Nubain works and morphine works. But the biggest thing about ketamine, it's working through a different pathway, in the NMDA receptor pathway. So when you that's why it's good for breakthrough pain as well, because if you've given somebody like repeated doses of fentanyl and they're just not, pain's not under control, and you switch to ketamine, well, now you're going around kind of a different pathway to try and affect pain. That's a great thing, right?
Okay. Yeah.
If you start to add Nubain on, as you're decreasing your ketamine, well, you're just working at the mu receptor, and that's great, especially if you're trying to like get somebody off of the drip maybe, and now I'm just transitioning into pain control, just like you would do it for your fentanyl or morphine or whichever. The good news is, though, is that I'm not getting histamine release if I'm using Nubain. I'm not getting respiratory depression. I'm not adding that on top of the problem. And so in that kind of a case, in theory, it's a safer way to go. It just may not have as great of an effect on whatever pain that they're having. Now, a lot of people might say is like, well, I've used Nubain all the time and it works great and yada, yada, yada. Fine. Great. You know what I mean? I'm just telling you from my side of the house, it's like, it depends on Nubain even though the book says it doesn't have a ceiling effect on pain, it kind of seems like it does. Yeah. Is kind of my point. You know what I mean? It's like, once you're at a certain point with your Nubain and they're still in a lot of pain, you might need to switch over to your morphine or whatever else that you have, if you really want to kind of get that under control. But you can absolutely use your Nubain with the, as an adjunct to the ketamine drip and starting to get them off the ketamine drip with not as much worry about the respiratory depression as some of the other drugs, Okay.
Yeah. I guess how exactly would I do that? I have a drip running at one every 3.
I would look at I'm guessing they're breathing on their own. You're not, obviously, because you're trying to get them off the drip. I would start with 5 milligrams, see how they react to that.
With the ketamine continuing to run at its normal rate?
Yep. Okay. As long as I haven't added another narcotic into the mix. Okay. Kind of a thing. So if, let's say, I had given them fentanyl, then I'm going to let the fentanyl run its course, and then so fentanyl goes away in an hour, right? Yeah. So as that hour is starting to come to its end, now I'm going to transition I'm going to try 5 milligrams of Nubain, see what the respiratory rate does. I'm going to let it work before I give any more of it. And then as long as I'm staying in that, 10 to 16 range where I want to be as far as the respiratory rate, then I can start to switch over, start decreasing my ketamine drip, and eventually I'm just turning the ketamine drip off. Understanding now, when you say ketamine drip, is the Versed in the bag as well?
No.
or straight ketamine. So once you turn that ketamine drip off without Versed, you need to know that's going to go away relatively quick as far as them starting to wake back up.
Right.
10 to 15 minutes, they're going to start waking back up depending on how long the drip has run.
Right.
So that's
just real quick. You're not talking about just turning the drip off. Are you talking about just turning it down? Maybe change it from 1 every 3 to 1 every 6 or 8, something like that.
Yeah. Typically, like if I think I'm kind of weaning them off at that point, let's say I was running it at, let's say 30 cc's an hour at this point, right? I can decrease it to 20 cc's an hour for 15, 20 minutes and then cut that by 10 and then shut it off and let them start to wake up on their own and just watch the respiratory rate as far as that goes. Great thing with again, with ketamine is you're using a drug that really doesn't cause hardly any respiratory depression. And you're switching to a drug that really doesn't cause a lot of respiratory depression. So it's, it's not a bad transition, especially that's what you have, Sometimes where people make a mistake is when they transition from the ketamine and people start moving around and they start making these weird sounds and they reach over and they whop them with a big dose of like morphine or something like, and now it's like, oh crap, now they're breathing 4 times a minute and, now I'm watching them that much longer until the morphine starts to wear off, So,
that's also a good point. Like you mentioned, like sometimes Nubain just isn't enough. Right?
Yeah, sometimes.
So let's say I want to use Nubain. I want to conserve my ketamine or my fentanyl or whatever, my short-acting agents for as long as I possibly can. Nubain is my long-acting opioid. I want to use that to extend, right? So I give him his, 10 or 20, or let's say we get to our max of 30 milligrams of Nubain. Like we've gone as far as we're going to get with Nubain, but I can maintain that. But he's still kind of like, just visibly, he is definitely uncomfortable. He is definitely feeling some of this, and his discomfort is freaking everybody else out around him. So I really just want to shut this off. Is it okay to add, 10, 20 milligrams of ketamine and just try and, like you said, go do the roundabout, hit another side of that receptor or a different place in the nervous system and just kind of chill it out? Or am I heading into trouble?
No, I mean, you can absolutely do that. Again, that's kind of a breakthrough pain type of a use of ketamine in that scenario. Even better would be like if I gave low dose ketamine to start with before I even used the Nubain. It's probably going to work a lot better long term if I'm really trying to stretch my medications out, kind of thing. But, if I was holding off, you're not causing really any more of a problem if you decide like, okay, let me try and give this guy 20 milligrams of ketamine, see if that works for breakthrough pain. It shouldn't really affect their respiratory rate at those dosages. And, see if that works for him before I start switching over and say, like, I'm going to start to pull out one of the bigger guns, morphine, fentanyl, dilaudid, something along those lines. So,
okay.
Yeah.
How does Nubain react with something like Versed?
So not as exaggerated as you. So when you Versed being a benzodiazepine, a lot of times you see in the literature of a synergistic effect anytime you combine a benzodiazepine and an opioid. So we think about Versed, morphine, Versed, fentanyl. It's still going to have And the big thing we're looking at is respiratory depression.
Yep.
It's still going to have a little bit more of an effect, but definitely it's not going to be, unless something weird is going on, it's not going to be like you would see with morphine, or especially like fentanyl as far as that side of the house goes. So it does have an effect. But again, as far as from the safety side, as far as respiratory depression is not going to have as big of an effect. So,
okay.
Yeah.
So adding, let's say we wanted to add Versed to this situation for whatever reason, to start at like mere 1 or 2 milligrams of Versed, see what happens. If you got where you need to go, perfect. If you didn't, okay, then maybe another 1 or 2, just kind of slow step your way. So you're not bagging somebody that you didn't want to.
Yeah. And I'll tell you another thing too is when we were talking about the dysphoria side of the house, sometimes what people think is if I'm getting somebody and I've got Nubain and they're getting the dysphoria, I'm crawling out of my skin, I'm cold, clammy, I'm sweaty, I'm freaking out. It's not the same thing as freaking out on ketamine. Ketamine, if someone sits there and says, like, I see little green men in the corner, they mean it. They actually see little green men. Don't argue with them. You know what I mean? Because they're actually seeing it, that kind of a deal. That's not the same thing as the Nubain dysphoria type of reaction. Now, if you were to give Versed for the dysphoria of Nubain, it will calm them down some. Like if I don't have any other drugs to switch to, then 1 to 2 milligrams of Versed will calm them down. But if I have another option as far as like switching off of the Nubain to a different narcotic, if I start to see that reaction, I typically try and just switch to the other narcotic instead of trying to keep knocking it down with Versed, type of a deal. But, my standard dose of Versed, and we're talking adults, is typically 2 milligrams for almost everybody that we're dealing with in the adult world. If it's a trauma patient, I'm worried about hypotension. I may start with 1 milligram, but anywhere from 1 to 2 milligrams is kind of that beginning dose that I'm going to start with. Yeah.
Cool. Is there anything else that you'd like us to know about Nubain as far as its practical use?
Let's see. I would say the other question that gets, I think, asked at times is, can we go the other direction with Nubain? Meaning, we talked about, stretching. If I've been using Nubain, can I switch over to something else? You can also do the reverse. Let's say I was starting with morphine or Dilaudid or fentanyl, especially if I was doing a procedure type of a thing. I was setting a fracture or something that's very painful, and I just didn't think the Nubain was going to, help enough. Is that, once the procedure is over with and I want to save again my fentanyl or whatever my other narcotic of choice is, I can switch back over, or I can switch to Nubain and try and stretch out the medication as that way as well. So there's nothing wrong with starting with Nubain and switching over to the other drugs if you have to. And the reverse is true. There's nothing wrong with starting with morphine, especially because you're going to reverse some of that respiratory depression that you're worried about in the first place. And that's definitely a way to go. Type of a deal. I think the other thing. Would
you stay with the same dose that you gave, like the morphine, like 10? Let's say 10 milligrams of morphine. Worked perfect. Give them 10 milligrams of Nubain.
Yeah, I absolutely would, because if that's what's working with morphine, you got to remember it's like they're not quite getting a full 10 mil. They're not getting quite the full equivalent, really, because part of the drug is reversing itself. So if I was using, let's say, 10 milligram dosages of morphine, yes, I'm going to use 10 milligrams of Nubain. Then I'm going to watch and see if I get the effect that I want, and then I'm going to kind of go from there. Which kind of goes down one of the roads too of it's important whenever we're talking about the different types of drugs. I know I used to joke, I think a bunch of the medics back in the day, when I die, we're going to go to my funeral and tattoo titrate to effect on my tombstone. I'm just going to chisel it in there, because I said that, so many times. But what sometimes gets left out of that is titrate to what effect? Because when I'm teaching this stuff, it's titrate to effect, yes, but what is the effect that I'm looking for that drug? And when you're looking in the narcotic world, one of the very best, the reason we're talking about respiratory depression over and over again is because it is, in my personal opinion, the best thing to look for as far as is my pain control being effective, for my patient. It's also one of the easiest things to look for, kind of a deal. So if I am giving a narcotic, the effect that I should see when I'm giving morphine, Dilaudid, or fentanyl is once I give that dose of that medication, as far as the respiratory effect, I should see a decrease in the respiratory rate. So it should slow down. I should see an increase in the tidal volume. So they should take in, kind of the bigger, deeper breath, finally. Overall, though, it's going to decrease my minute ventilation. And therefore, if I'm lucky enough to have end-tidal CO2, like an EMA or whatever it is I have, I'm going to start to see my end-tidal CO2 start to rise up because I'm blocking the receptor in my brain. Those are the things that I should see, type of a deal. So anytime I'm giving any of the narcotics, even Nubain, I'm looking for some of those effects. The difference is with Nubain, I'm just not going to see as much of the respiratory depression as I'm going to see with those other narcotics. But I always think that's an important thing for people to understand whenever they're given any drug is what do I expect to actually happen to know that this thing is actually working? Kind of a deal. Sometimes we look for the wrong thing. Sometimes, especially with pain, people focus way too much on heart rate, blood pressure. You can get fooled with those depending on the drug that you're giving. Ketamine's going to increase heart rate. Ketamine's going to increase blood pressure. If you're given Demerol, it's a derivative of atropine. Demerol is going to increase heart rate. Therefore, it may increase the blood pressure. You know what I mean? Yeah. And that's why respiratory tends to be kind of the big focus, especially in a field environment when you don't have all the bells and whistles. It's like, am I getting what I expected to get?
Just another question about your assessment other than respiratory. So would you look for those signs and if you didn't have them, give more, even in a guy who's like, yep, I'm good.
Everybody's different, I typically or the reverse is true. You want to see one of the funniest things in the world is going into the recovery room after somebody's had surgery. Especially, I'm not bagging on anybody, but especially like a new recovery room nurse, someone will be totally asleep in the corner, breathing 8 times a minute. And they go and wake them up and be like, excuse me, how's your pain doing on a scale of 1 to 10? And they shoot up and they're like, it's a 10. And then they're totally back out again. And then they're like, oh, I got to give them pain meds. Like, hold on, they're only breathing 8 times a minute. The only reason that, the kind of the flip is true too. You got that guy who's just really, they're chewing gunpowder to get through everything. You're like, hey dude, I'm just going to give you a little more pain medicine to, but again, it's for me, it's respiratory rate, because how do people breathe when they're in a lot of severe pain? They pant like a dog. They breathe very shallow and they have trouble even forming kind of sentences. It's hurting so bad. And that's where it's like, if I'm going to give my narcotic, whether it's It could be Nubain, it could be more, whatever it is. I'm looking for that respiratory rate to come back down, get me back down into at least the teens, somewhere in that realm, preferably kind of 8 to 12, yep. and they're finally kind of, and they're taking that big, deep breath. Fantastic. Maybe I have end tidal, maybe I don't, but I'm starting to see like now I've got a better indicator if that guy's his pain is actually under control. So yeah, sometimes you gotta convince them like, I'm good. Like, all right, dude, I know you're good, but we're getting ready to ride in the back of this helicopter for the next 4 hours. And
do me a favor. Here,
do me a favor.
Stay still.
Yeah, here's a lollipop. You know what I mean? It's like, so this really will make you feel a little better,
Yeah.
So yeah,
cool.
Absolutely.
I think it's a perfect way to end. Thank you very much, Brett. I really appreciate it.
Anytime, Dennis. It's been a pleasure, man.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.